Hi, everybody. Good morning. Welcome to our presentation. I'm going to share my screen now and get started. I'll possibly give just a few more minutes to make sure that everybody's had a chance to join from all the exciting activities this morning. So I'm just going to share my screen right now. Welcome to our presentation called Food Access as a Social Determinant of Health. What is the community saying? Just a few housekeeping items. You will probably stay muted this whole time. We have a couple specific times for engagement, questions, discussion. And we were thinking that we could do a combination of writing things in the chat, and at the same time, you could raise your hand and we could unmute you. This might be a little bit challenging because there's only two of us, but we will try our very best. Throughout the session, feel free to put questions in the chat because when we get to those moments, we can sift through and look at them. And maybe even if we don't get to them all, we can do something afterwards where we talk about them. I am going to be putting a few links in the chat throughout the presentation of really helpful resources, articles, things to read about food prescribing, which we're going to be talking about today. So save those, put them somewhere nice for a nice day when you can read them. And I'm just going to give it a few minutes. I see a lot of people kind of signing in. I'm going to give it a few minutes actually, but we can just take this time to take a little bit of a deep breath. You've probably been on your computers all day and it's only 11:30 right now. So take a breath, drink some water, and just get a bit grounded for the presentation. Oh, why can I not change? Oh, there we go. Okay, so I am Abby Rector. I'm a registered dietitian and program lead of the Fresh Food Prescription Program at the Guelph Community Health Center. And I am on the SEED team. So the SEED is a food access location or service that is kind of incubated out of the Guelph Community Health Center. So we're a program of the Guelph Community Health Center. And my pronouns are she, her.
My name is Matt, or Matthew. I use he, him pronouns, and I am an assistant professor in the School of Public Health and Social Policy way out at the University of Victoria. But I used to call Guelph home, and that's when this partnership with the SEED first kind of started up. And so I've been working on the Fresh Food Prescription Program in coordination with the SEED and the Guelph Community Health Center since about 2019. And I'm very happy to be here to assist Abby with this presentation and talk specifically about the research aspect of it.
And I'm just to go back, I may put the links to the articles and the other resources at the end because I'm not able to access my computer while sharing my screen. So wait for those at the end. They will be exciting. Why? Oh, there we go. So I would like to start with a land acknowledgement. So this is a virtual conference. So we're all situated on different land on so-called Canada or Turtle Island. So I would like you to take a moment to reflect on the land that you're on, where you're coming from today. If you don't know that, find out. I am in Guelph, the traditional lands of the Mississaugas of the Credit. As a settler, a guest on this land, and a registered dietitian doing nutritional science research and dietetics, it's very, very important to address the harms that this sort of work has done in the past through nutritional research and colonialism. I work in healthcare. There's lots of harms being done every day with healthcare to Indigenous people and other people. So dietetics is deeply rooted in colonialism. Lionel Pett used human suffering in residential schools as an opportunity to gain power by doing nutritional science. And that actually led to the Canada's Food Guide, which many organizations use to talk about nutrition. So it's very important that we acknowledge that past in this sort of research and move forward in a way where consent is very important and consultation with community. My call to action, one of them today is to look up the learning that is on the screen. So it's from the Nourish team and allies. It's a training that they created to help people address colonialism and harms against Indigenous people within healthcare, and work like this in caring work and healthcare work. They have about 2,000 people signed up, or 1,300 people signed up, but only about 200 people have completed it. So if you want to do it, think about it, have intention behind it so that hopefully you can follow through and finish it and change things in your practice. Yes, I will place the link in the chat at the end of the presentation. Absolutely, I will. You can also Google Nourish, Nourish Food is Our Medicine, and hopefully it will come up, but we'll make sure the chat's put in. It's a free learning. I think it's about 15 hours. You can do it in a team. You know, maybe put it in your calendar every 2 weeks so that you can get it done. Because I know sometimes these things, we always move them on our calendars when we get busy. Yes, so I would love you all to check that out.
So this is the agenda of what we will be discussing in this presentation specifically. First, we want to start off with contextualizing our work within broader food insecurity landscapes in Canada, as well as social determinants of health frameworks, and within the social prescribing landscape as well. And then we'll talk about food prescribing programs, and specifically our food prescribing program that we have been partnering on since 2019. We'll discuss some of the strengths of running food prescribing in interdisciplinary healthcare settings like community health centers in Ontario. And then we want to share, because we really think it's important to centralize the voices of participants and people who use these services. We want to share a testimonial from one of the community members who has participated in FFRX, which is what we call our fresh food prescribing program at GCHC, which is the Guelph Community Health Center. And then we want to talk about challenges with respect to equity and justice in accessing programs like social prescribing or food prescribing programs, as well as some of the possible solutions or adaptation measures that we have employed to address some of these challenges. And finally, we'll have an opportunity at the end for some comments and questions from the audience. And again, just to reiterate, we'll ask people to raise their hands and we'll be able to unmute them and they can ask their question. So our go ahead, Abby.
There's a lag. Our objectives today are to increase understanding of how to utilize a multitude of resources within social prescribing, primary health, and interprofessional teams to implement Fresh Food RX program. So I feel food prescribing fits well into the model of the health center and primary health, with some caveats, but I'd love for you guys to feel more confident in how it fits well. And I'd also like to increase, or we'd like to increase awareness of strategies to overcome barriers to reaching populations affected by food insecurity with food prescribing, We've done a lot of learning through this process, and I'd love to share that so that if you start up programming like this, you can use some of these strategies.
So I mentioned that we wanted to kind of situate this work, food prescribing work, within broader food security landscapes. And we've had lots of conversations internally as a team, and we're trying to now kind of broadcast some of those conversations out into the world as well, and have broader discussions with other healthcare providers and researchers and people who work in food prescribing and social prescribing more generally. So I think it's really important to recognize at the outset that that food insecurity is primarily an income-based issue in the Canadian context. So if we look at the relationship between income and severe food insecurity, we see a very, very drastic correlation there. We see that people who are low income are much, much more likely to be experiencing food insecurity in comparison to those who are high income. And we see that this is also kind of a cyclical issue, because people who are food insecure are much more likely to spend greater amounts on their healthcare. And as a result of that further drives kind of a cycle of poverty and food insecurity. And within food prescribing, we recognize that we are not addressing many of these social determinants of health that lead to food insecurity, including income. Really, what we're proposing through food prescribing programs is somewhat of a Band-Aid solution, where we're providing better access to healthier foods for people who need it in the moment through what we hope is a non-stigmatizing program. But ultimately, we recognize that these programs are not a long-term or sustainable solution to broader patterns that influence or affect food insecurity at the household level. So I think it's important to keep that in mind as we go through this. We have to recognize that these programs are important, but also we need to advocate from within our positions in order to promote broader solutions to food insecurity that focus on equity and justice at the societal level.
So because this is a social prescribing conference, I would like to talk about our food prescription program within the social prescribing model at the Guelph Community Health Center. So Carrie Cummings and Kim Richer, shout out, do a lot of the social prescribing work at the Guelph Community Health Center, and we are able to use some of that infrastructure for food prescribing. So what that looks like is sometimes in the EMR or the electronic medical record keeping, there are avenues for social prescribing within there that we use for our program. So providers, dietitians, social workers, community health workers, health guides can refer people from the community to this program in an electronic fashion. So we use that really well. And also Kim is the community connector, which is a role that's an amazing role. And it was in place for social prescribing and the pilot that we started at the health center. And she helps us a lot in connecting with people who are in our program. So although we're not just a socializing program, we are prescribing a social determinant of health, a basic need, a human right of food, and we feel that is important to do within social prescribing. We do provide some social connection in our program, which we will get to later. Another thing we use is social prescriptions are always coming through the electronic medical record keeping system or through the community connector. Even though our program is closed right now, we are collecting a wait list of people that could benefit from our program, which is really helpful infrastructure for if and when we run our program again. And at the same time, the community connector through social prescribing is making sure that people who don't have the service of food prescribing right now are having access to other food access supports. Okay, so I wanted to quickly go through this great pathway from the Canadian Institute of Social Prescribing. Shout out also, I think they're doing a presentation later or have already. So this is not a typical, but this is a pathway you can follow with social prescribing. And I just wanted to quickly go through what it looks like for food prescribing within that particular pathway. So I already kind of discussed that people enter the pathway through a prescription or a referral from their primary care provider, dietitian, social worker, community health worker, parent outreach worker, or the community connector, Kim. She then connects them to me or another member of our team, where we go through a lengthy consent process because it is part of a research study, which we will talk about later. And we connect them to the program. We get them started. We explain the program. And then people start attending our program or receiving the prescription or receiving the food. It is, and we will describe what that looks like in more detail. At our program, we need quite consistent follow-up. So it may be thought that it's, you give people food and that's that. You give people prescriptions and that's that. But because we are creating an intervention, we have a certain system of how you order food, and that comes with barriers to people accessing our program. It was very important for us to have constant follow-up to make sure people had what they needed to actually access the food, which we will describe in more detail. So we follow up quite a bit. So some of our participants get weekly follow-ups where we call them every week to help order. Some people, we talk to them 3 times a year if they have lower barriers to using our program. And unfortunately, people do have to exit our food prescribing pathway because something we're going to talk about, we don't have sustainable funding at this point. So people do exit our pathway, but the nice thing about us using social prescribing infrastructure is that our community connector or other providers can continually prescribe or refer community members to other food supports and other food programs to hopefully fill the gap before we are able to do more food prescribing work.
So now we want to actually talk about the structure of these programs and how we've facilitated these over the past couple of years. So the Guelph CHC has been running food prescription programs since 2019, and primarily this has happened in 2 phases. Phase 1 occurred from the fall of 2019 to the spring of 2020, where participants were enrolled on a rolling basis to participate in a 12-week intervention program. So each participant who was enrolled was referred through a healthcare provider or a community connector, so physician, nurse practitioner, social worker, dietitian, someone who was connected with them through the Guelph Community Health Center. So these were existing patients from the roster of patients at the Community Health Center who were experiencing food insecurity and also could benefit from improved access to fresh fruits and vegetables. So often they had a cardiometabolic or nutrition outcome or a condition that they were managing. And so participants were enrolled, 60 participants total, again, on a rolling basis. Each participated in the program for 12 weeks and received $10 per person per household per week, up to $50 per household per week. And these vouchers that they received were eligible to be spent at a in-person market that was held at the Guelph Community Health Center and facilitated by the SEED, which is a working group of the Community Health Center. And that market ran weekly during this time. Now, the program was running through March of 2020. And so when the COVID-19 pandemic initially happened, there was a transition period shifting from a face-to-face market to an online groceries from the seed food delivery service. And so participants who were still in the program at that time actually did have this transition period and then fulfilled the remaining weeks of the program through ordering their food online instead of going to face-to-face markets. We've always included an important evaluation component of the project. And so that's kind of where I've come in, and we've worked with graduate students and research assistants to do this work. So in this first phase, we just did pre and post surveys and interviews with participants. So we were looking at the impacts of the program on household food security, on fruit and vegetable consumption, on self-reported health outcomes. And we're also in interviews exploring kind of broader supports of the program and how people navigated the program, barriers to access, as well as the social impacts of the program. And Abby will touch on that a little bit more later. So when we evaluated the impacts of that first phase, what we found was that the program itself improved fruit and vegetable consumption, improved household food security, and improved self-reported health in just 12 weeks. So this gave us strong justification to continue with the program as best we could. And so we started planning for a larger scaled up version, which we called FFRX Phase 2. And that version was initiated in the summer of 2021 and ran through until about just a couple of weeks ago, we finally finished. And this was a one-year program. So again, participants were enrolled on kind of a rolling basis for a few months. And they received, for a full 52 weeks, they received, again, $10 per person per household per week of fresh fruits and vegetables, except instead of a face-to-face market, because initially, at least in 2021, the face-to-face markets were still not happening. Everything happened via an online market, and food was delivered to the doorsteps of participants. Again, we conducted some evaluation, and the biggest difference here, in addition to the longer timeline, was that in addition to pre and post surveys, we did clinical health evaluations. So we linked electronic medical records, and participants had blood samples taken at the beginning and end of the program, and we're looking at those blood samples for nutritional and cardiometabolic health outcomes, or biomarkers and indicators of health outcomes. So we, as I mentioned, we just finished. We're in the midst of kind of pulling the data right now and doing some summary statistics. So we actually don't have any results to share, but we really hope to share that with the broader social prescribing community in the future. And there will be some reports, publications, and conference presentations, meetings. There will be lots of opportunities for sharing that knowledge and that evidence that we produce through this program. We're in a kind of a transition phase right now where we're looking at potential opportunities to again scale up, looking at funding opportunities, and trying to figure out how to continue doing this work, whether or not research is still going to be an important component of the work moving forward, how big we want to scale up, and all of these kinds of big questions. And so we hope to engage at some point in the winter, probably broader social prescribing communities in Ontario, community health centers in Ontario, and folks who are interested in this type of work in any potential follow-up stage, at least just to keep people informed of what's going on in Guelph.
Okay, so we've gotten some feedback from participants along the way, and you can see on our screen, hopefully, some of the comments people have said, which are very impactful. We're also doing more feedback and more stories like this. We're hoping will come out in our qualitative data that is ongoing right now. And I just have one other note from a participant that they wanted to share on my phone outside of these quotations. So she explained that she often feels invisible as a person of color, that walking into stores, she feels like she is not acknowledged or respected. When she spoke, or when she spoke about walking into the seed warehouse, she said, everybody was lovely. I was acknowledged. They were very good, and I left feeling very good. And then another participant felt they were able to save money from their ODSP check and could bring her son to a trampoline park, and this meant a lot to her. We really believe in these stories. We really believe that this is the most important part of this program, is ensuring that these stories come out in this work, so that we know not only is blood work changing, is people's blood work changing, but how are people feeling and how does this program affect their lives? So I am going to talk about some benefits of food prescribing within a clinic setting or a health center setting, more specifically, because that's the experience I have. So within food prescribing, food prescribing program, we have access to health professionals and health information. So that has been very an important facilitator to our work, especially with collecting biometric data. When people consent to the program, they consent to us talking with their circle of care team and accessing personal health information. And that's once they consent, it's very easy to access that because we're part of the clinic team. Additionally, because we can collaborate with primary care providers, social workers, dietitians, community health workers, they often know who needs food support, hopefully, especially at health centers, because we're used to asking about those things. And therefore, we're able to collaborate more. Another example is if somebody is in the program and they're not accessing the program a lot, I collaborate with their social worker or their dietitian to see how I can better meet their needs. Because there's just some things I don't know about the community members or the participants that the people at the health center may know, especially because at health centers, we are used to that wraparound care and helping with barriers that folks are experiencing. I think it's also important and helpful that this program is within the clinic setting, because it's forcing food security to be part of that clinical dialogue. So because we use social prescribing infrastructure, it is already in the chart that, somebody is part of this program, or people can see what other programs they've been referred to. And then right away, maybe it's not appropriate to say, you need to eat more fruits and vegetables. Or maybe it is now appropriate to offer that recommendation because people have access through this program. It is becoming more important to do this so that we are not recommending things to people when they don't have access to things like food. Something that's also helpful is because dietitians at our center are very, very good at tracking or documenting food insecurity, we are able to pull some data both on, who's experiencing food insecurity and who is also having a chronic nutrition-related health concern. So that helps a lot with recruitment. And one of my goals is to get everyone on the healthcare team to start tracking food insecurity more consistently in the EMR, because I think it makes these programs easier to do and reach more people. Also, hopefully, many of our participants, community members trust the health center. They trust that our intentions are good and that we are creating programs that hopefully impact them in a positive way. So because we're communicating with community members as part of the Guelph CHC, many people trust that and know that we have good intentions and that we are creating a program that is hopefully going to benefit them. Now, we will talk about, there are some issues about, not issues, but there are barriers to overcome with these programs being part of a clinic that we'll talk about a little bit more later. So we are going to talk, we have a couple minutes for questions or engagement. I see some things coming through in the chat.
So I've been monitoring the chat a little bit here. So Kayla M asked about funding, and I responded in the chat. Basically, we've secured funding through a variety of different sources, mostly foundations. And now we're kind of looking at potential for academic sources of funding as well. We have some small amounts of funding through the Canadian Institutes of Health Research, but we're looking at opportunities there. But for the most part, yeah, big hodgepodge of foundations that have funded this work, which raises its own challenges, of course, for sustainability. And this is the primary reason why we've had to run in these phases, and currently the funds are not in place for the next phase. And so that's been a huge challenge. And I think we'll touch on that a little bit later about, participants exiting the program and coming to depend on it and rely on it, and then it's not being available to them long term, which is unfortunate and something we really want to fix long term with the GCHC. And then Abby, this is one that you should answer. Do you have a full-time dietitian for primary care at the Guelph CHC?
So we have two dietitians. So Shin and Shelly are two dietitians, and they do 4 days a week. So whatever, I don't know what that is in FTEs. And then I am the third dietitian, and I work part-time at the Seed. So we have, at least a full-time plus some more at the health center, always advocating for more, really. We do a lot of work, and we're all quite busy. Is this a program that other community agencies can refer clients to? Great question. I'm trying to think. We are pretty open in our program. We're not very strict. For example, the one thing is right now you have to have a primary care provider at the Guelph Community Health Center. So I have had other community agencies refer to me, and like CMHA and other community agencies in Guelph. But the limiting thing is that they have to have a health provider at the health center, and that is because we are collecting this biometric data, and that would become much more difficult if it was another doc on board or another nurse practitioner. It's something we're looking at in our expansion plans, and we really want to do that. But it's going to be, it's a challenge, but we hope to scale and increase access to our programs. How does the major increase in food prices anticipated this upcoming winter affect this program and food insecurity in general? Is there also a focus on local sustainable partners? So the money we're giving was based on old numbers of food prices. So bottom line, it's not enough. We need to increase it when we're doing another phase. This program, I don't think we can provide like access to all of the food someone needs, but we do want to make sure that it's worthwhile and people are getting, that it is prices that it makes sense that people are using our program. So we will have to provide more money with upcoming increases in food prices. And is there a focus on local sustainable partners? I would say yes, there is. So there is a momentum in Guelph that there are with this work. I think we can probably answer a couple more right now and then leave more to the bottom. Do you have someone doing social prescribing as well as the food prescribing? So we have the health promoter does the social prescribing kind of like work. She works with the community connector, Kim, which does most of all of the social prescribing. So she gets the referrals, reads through the social prescribing referrals, and connects in whatever way works best. Food prescribing, it's basically, so I run the program. I have support from my seed team that do things behind the scenes to make sure the food gets out. And then I work very closely with the research team. And we are able to use resources through the research team, like research assistants or students, to help with some of the other food prescribing work at the health center. And one more. Have you been able to partner with grocery chains or restaurants? At this point, no. The seed is partnered with Second Harvest, so we do get high quality food surplus that isn't necessarily like food prescribing based, but our participants of the program get access to groceries from the seed, which is an online grocery store, and they use their coupons on there. and they get access to this free food that is likely coming from grocery stores. But no other formal partnerships going on there right now. I'm going to move on just for the sake of time. I see other questions coming in and we will try our best to get to them. Okay, so I am going to play an audio recording of a participant in the program. I hope that it works. I'm going to play it, and then hopefully Matt can give me a thumbs up if he's hearing it okay. If you're having troubles hearing it, please put it in the chat and I will use my limited tech abilities to try and help with that. Where are we? Share sound, share. Okay.
Okay. And have you been enjoying it?
I
Can you hear that, Matt? Okay.
like it sometimes, and sometimes I get too much,
Yeah.
and it goes to waste.
I
Honestly.
see. Yeah, for sure.
It paused there, Abby. I'm not sure if it's still playing for you.
Sorry, I did something wrong. I'm just going to do it and not touch my screen.
Lettuce at the peak of freshness, and it's really frustrating for me to maintain it as long as I need to keep it.
For sure.
Is that okay, Matt?
Yeah.
Okay.
Yeah, like it's not peak freshness. Like you'd have to eat it exactly that day and then you can't and then it goes bad.
Yeah.
Yeah. What do you like about the program?
I like the berries, and I like cantaloupe, and I like being able to buy things at a reduced rate.
Yeah.
I just wish that FFRX was more than just vegetables. Like,
Yeah.
I wish that it include reduction on milk, reduction on breads, reduction on eggs, cheeses.
Yeah.
You know,
For
stuff that you could build a meal with, right?
Yeah, and lots of people are saying they want that. You're not alone. Like, think about, at the beginning of the pandemic, when, remember I was going to the food bank for you or Hope House. Like, does this provide you something extra? Like, is it
Oh, yes, this is definitely an extra. It definitely supplements my diet and helps me get the nutrients that I need. Because at the food banks, you don't always get the vegetables and the fruits that you want, and this way I can get the stuff that I want and the stuff that I need, and I get my pears and my bananas and my blueberries and my strawberries, and I can get my lettuce and my cucumbers next week. And
like, does it feel
celery
different than going to those places?
I love it.
Like, if you
All
could...
I do, seriously, is open the window and the bags just come on in.
And it's stuff you chose, which is
stuff I
nice.
chose and paid for, and it's great. It's like, bravo.
But some people are saying, like, why are we wasting our time with these programs when we should be spending our time advocating for the government to give you more money on your ODSP check? What do you think about people that's, like, if some were to say that?
It's a very hurtful thing to say.
Yeah.
It's a very mean thing to say. It's mean-spirited to say something like that.
Yeah.
Programs like this help, but advocating to change the system would take more than just the city of Guelph. I'm sorry, it takes more than just the city of Guelph. If every citizen in Guelph said, we want a raise in the ODSP, the government wouldn't give us one friggin' swallow of hello. And living below $7 an hour on a 40-hour week on ODSP is really hard when living wage is $15 an hour.
Yeah, seriously.
So it makes it difficult. And programs like this help you get through, and help you make better decisions, and you can plan your other money better because like you've got this part of your budget covered. You got your veggies covered.
Yeah.
You don't have to worry about having the nutrients that you need to get through. Like you just relax, just eat it. Go ahead, just chomp it. Relax,
So
just eat it.
So it sounds like you want this program to continue.
Yes, I would love for this program to continue.
Okay. But
And
you're saying
expand.
expand to all foods.
Like even if you could give me like 50 cents off a loaf of bread. Off the current price. That would be great.
For sure.
Because that adds up.
Oh yeah, for sure.
After 4 months, that's $2 I've saved, right?
Okay, another question people have about these programs that I'm curious is, like, do you think it needs to be connected to the health center like it is? Or do you think it could just be something on its own? Like, do you feel you find out about programs through the health center quite a bit?
I do generally, yeah.
Okay.
Can you
It's
guys
usually
hear?
through the health center
I can't hear
connect.
anything.
Oh. Sorry, I just paused it because somebody had come over. I hope that people are hearing. If you can't hear, if I'm gonna leave my email at the end and I can send it to you directly. I'll ask the participant if that's okay. But I would just ask that you stay muted because we are playing it. I'm sorry if people can't hear it. There's a few more minutes left.
I can't hear it playing now, Abby. I'm not sure if that's.
What about that? No? Okay. Sorry, everybody. It's just a bit of a learning curve for me. Matt, would you be able to give me a thumbs up in the next minute if you can hear it?
Yeah.
Oh, okay, just one sec. I closed it. Sorry, guys. Oh my gosh, I'm so sorry. You know what? I am just gonna pause it there and just for time, begin the rest of the presentation. And anybody who wants to hear more, I've listened to it a lot of times, so I can speak to it more at the end of the program, at the end of the presentation. Okay. Matt, can you see this?
Yeah.
Okay. So that was one of our participants, and I hope that you got some information from her about the program. So there are challenges in enhancing equity in these programs and access that we would love to talk about. And I have some links that I'm going to share, some really good articles written by people that talk about this. And I find that really important and helpful in my work. So I will put those in the chat at the end. So there is, like I already talked about, there's an inconsistent charting of food insecurity by clinicians, which can cause challenges with inclusion for the program. So some doctors, may not be asking about food insecurity, therefore it's not getting charted. And we do sometimes pull data to try and recruit more people to this program. Another problem is that if people don't access primary care, they will not have access to these programs. So they won't, nobody's even charting their medical care because they're not accessing services through primary care, which is a concern. So that is definitely a problem, and one that we hopefully can work on. Matt, I'll let you talk to the next point.
Yeah, so we wanted to touch on some of the barriers to accessibility of the program, and these come through in a few different ways. So, I mean, first of all, of course, we are accessing patients through their healthcare providers and through the Guelph Community Health Center. And so there's a gap there in that there's likely a substantial portion of the population in Guelph who are unable to access even the healthcare center, the healthcare network in general, due to a variety of different accessibility challenges, whether those be mental health challenges or agoraphobia or other types of accessibility issues. So there's a gap there in that these programs, when run through a healthcare setting, may miss a portion of the population who are unable to access healthcare settings. There's also accessibility within the program. So we've, for example, and this is something that was addressed by one of the people asking questions, is that, we are operating this through an online groceries from the seed model. So there's an online kind of marketplace, and some participants have experienced challenges accessing that because they don't have a computer or perhaps the technological literacy to go through and order their own programming or order their own groceries. But we tried to address these through by providing opportunities for participants to access and use the program in other ways. For example, some currently call in every week to the customer support team at the CHC who do their ordering for them. So building in these kind of accessibility mechanisms is really important. Another big thing is just the cultural congruency and acceptability of the foods that are provided. There's lots of newcomers and folks from other cultural backgrounds who are participating in the FFRX program. And while we've tried our best to provide a diversity of fruits and vegetables that address kind of cultural needs of participants, there's still lots of folks who aren't able to access the foods that they're used to accessing through this program. And so I think it's important to ensure that in any kind of scaling up, we consult with the community more broadly, and we ensure that culturally acceptable and congruent foods are being provided through the groceries from the seed program and that those are accessible to FFRX participants.
Additionally, these programs may promote a false dichotomy of good and bad foods and sometimes rely on a narrow definition of health. So there is paternalism and a lot of power in prescribing these programs. And because we're only providing fruits and vegetables at this point, that is putting across a message that fruits and vegetables are only, are good foods, are the foods that are going to make you healthy, are going to, those are the foods that people think you should be eating, which is not true. And also, can trigger shame, can trigger eating disorders, many, many things. And we believe that people should have access to all foods. And when we're doing a research study, there is there's a narrow definition of health within healthcare, and people's ideas of their own health vary widely. Everybody has a different definition, and we hope through our qualitative data that we're able to look at some of those different definitions of health and how this program makes somebody feel versus, is their blood sugar changing or things like that.
So a few of the solutions that we've tried to build into our program and that we recommend to anyone who's looking at integrating these types of activities or programs into their own healthcare setting or community health center. As a researcher, I often look at the research gaps and the evidence that we're producing, and I still see this as a very kind of new model and something that requires increasingly more knowledge as we kind of try and navigate the challenges and barriers to accessibility of these programs and things like that. So we've tried to integrate research, monitoring, and evaluation at every stage of the FFRX program, which I think has been really, really helpful in informing where the gaps exist and what we can do to improve the service. And I would encourage everyone else to do the same. Research is also needed, for example, on not only the qualitative and the quantitative components of how these programs impact people, but also for scaling up and potentially for advocating and approaching policymakers and trying to integrate these types of programs more generally into healthcare systems. We really need evidence on the kind of financial efficacy or effectiveness of these programs, how much money we're saving in terms of per participant, in terms of healthcare savings down the line by providing these kinds of preventive measures like food prescribing and providing access to food and food insecurity, because those are the types of questions that really provide us with the leverage and the persuasiveness to integrate these kinds of solutions more long-term into healthcare settings.
We are also beginning our journey in being responsive to participants' feedback. So for example, like you can hear the community members speak in the recording is, pretty much across the board, people want access to all foods and not just fruits and vegetables or more foods. So we started to be responsive to that by we provided a thank you honorarium for the data collection of the survey and the blood work, and people received money to buy foods from Groceries from the Seed, but they could use that coupon on all foods, not just in the store. So yogurt, milk, eggs, pantry items versus just fruits and vegetables. Many people are saying they need more money, like we talked about before, and we're advocating for that in scaling up the program. People have ideas for cultural foods that they want to bring into the store. We're beginning to be responsive on that. Lots of other feedback coming in that we feel very strongly needs to be incorporated to run a responsible program for the community. Also, it's very important that you build relationships with the people in your program, that you are interacting with them and making people feel like they belong in your program and that they're welcome and that their stories matter to the work that you're doing. Their stories or their truths. For example, so in our first pilot, we did have a social program that went on. People could come and eat together and hang out. It was very, very positively received, and I think it really helped our program be successful. We were hoping to do more of that in the second pilot, the 1-year program, but because of COVID, it was more challenging. So in future iterations, we hope to ensure that there's a social component. Yes. That is all I will say there. It's also important that we build sustainable programs with strong foundations. So don't do this work on the side of your desk because I believe it's not the most responsible thing to do for the community. We are really committed to running the program long term and hopefully building it into our health center because we believe that's, a more responsible way to run these programs. Which means adequate staff time. So we've found in our journey, it is easier to get money for food, but not always easy to get money for staff. And we hope that if we can build a really strong program, we can use our research and outcomes for future advocacy. Because like we talked at the very beginning of the program, this is not going to help people get more money on their ODSP checks or get paid a higher wage, which will help food insecurity. So we need to find a way together to use these programs to advocate, hopefully, if that's possible, for policy changes, income policy changes, things like that, which we aren't the experts on yet, but we're constantly chatting about it with other leaders in this work. We also believe that work we need to do is target equity deserving communities who are disproportionately affected by food insecurity. So people who are Black, Indigenous people are disproportionately affected by food insecurity, and we have not done any specific targeting or recruitment or systems changes within our program to address this problem. And that's something that we hope to do in the future. Okay, so we have 5 minutes, I believe. Thank you for bearing with my limited tech abilities. We will answer some more questions in the chat. I'm going to place some links in the chat for you guys to please look at, read through, get additional information, because there are others doing this work. How are we doing in that chat, Matt? I did want to mention, because it was a really good question. Somebody asked, like, how much food is someone getting weekly? So people are getting $10 per person in the family each week. They're buying food from Groceries from the Seed, which is a discounted grocery store. So prices are lower than that at the grocery store. It is hard for me to say, like, how much food. I wish I could say that, but they are the $10 or the $50 or whatever does go further than it would at the grocery store. I'm going to put the link to Groceries from the Seed too, so you guys can check it out. Yes, Jill, I hear you about getting more money for staff is a big problem. Does anybody have any other questions that we haven't addressed yet? Feel free to put it in the chat or put your hand up. I'm going to ask Matt to keep an eye on the chat, because I'm going to try and put some more links in the.
We had one question that we haven't addressed yet, from what I'm aware. I have been dropping answers into the chat as best I can here. So if you feel as though your question hasn't been answered yet, maybe just double check there. Yeah, our question was about food banks and partnering with the food bank in Guelph. Abby, do you want to address that? I think the question specifically was just whether or not we have done that or have considered doing that yet.
We have not done that yet, and there hasn't been a lot of talk on it yet. I don't think it's something. I don't think it's a bad idea. I do know that at the Seed, we strive to have programs that have dignity and are open to everybody and have more choice. And sometimes food banks don't reach that need, but sometimes they do. So if the food bank was willing to meet those goals on the project, we could definitely talk about partnering with them, especially because they do sometimes have access to other foods other than fruits and vegetables.
I just realized I had actually answered that question in the chat, so sorry. Another question was, are you able to address or flag other social determinants of health and social needs that are at the intersection of food insecurity with other data collected in the EMR?
I'm just thinking about our EMR. There is end codes for social isolation, inadequate social supports, low income, housing, problems with housing. I'm trying to think what else you could kind of collect. You can collect in the EMR, like if somebody needs interpreters or speaks a first language other than English that they might need an interpreter for, that would be helpful data to collect. You could collect if people have barriers to transportation and might need help with that for your programming, or just to reach their healthcare goals. Hopefully that helps. The links I put in, I didn't put them in a very nice way, but there's a link to an article we wrote about like equity problems within food prescribing, and a couple links from some amazing work from Food Share and the University Health Network being done in social food prescribing in Toronto, and they just came out with a really great paper. Valerie Tarusik has a good paper on why, you know, I don't know how to say this, like problems with food prescribing, other things to think about, which I think is really important to read and be aware of when you are doing food prescribing. I hope I put that in. I just
put I think we have to wrap things up here, but
yeah.
I just put our emails in the chat there. So, and feel free to reach out. We're happy to chat with other folks whenever. So thanks a lot for coming.
Really thank you. Thank you so much. We really appreciate you guys all coming and listening to us. And yes, the seed does have soup kits. I think I would think we can send them far and wide, I think. So check out our website. And I'm always happy to chat if people want to send me an email.